These image clips are now 6 years old, but I still remember this case quite well. It was the case of a 64-year-old male who was admitted to our hospital because of an inferior infarct, and he was actually about to leave the hospital already when he developed recurrent chest pain and ST elevation. So we performed another echocardiogram, and what we found was this scar here, which we knew about, but which was very thin, or had a very thin wall. You see, this is the left ventricle, this is the right ventricle, and right in this region with color Doppler we found a small little jet. So we had the suspicion that this was an ischemic ventricular septal defect. And if we just move the transducer to an atypical view, we actually saw that there was an aneurysm here, fairly large aneurysm of the interventricular septum in the inferior septum, and here was the jet again, which showed us that there was an ischemic ventricular septal defect. So after seeing this, and with the background information of the patient having an infarct, we immediately contacted our surgeons and planned surgery, but however the patient never made it because only hours after this echocardiogram the patient was actually dead. So this just shows you that complications of myocardial infarction can be very dramatic, and even if this does not look as dramatic as it seems, you only have a very small jet. There is a lot of dynamic in these complications, and unfortunately many of these complications end lethal. So as you can see from this case example, it's very important that we make the correct diagnosis of a complication of an infarct. This can be life-saving. The problem is, acute complications are fairly rare, so we don't see so many patients. There's no time or no room to practice. So to increase your caseload, don't forget to go to the Atlas section. We have a number of patients with various types of complications. But what is even more important is the fact that we have to get the patients referred to echo in the first place. Which issues will we touch? First of all, the very acute situations such as cardiogenic shock, myocardial rupture, ischemic ventricular septal defect, papillary muscle rupture. Then other things such as right heart infarct, thrombus formation in the acute setting and in the chronic setting, mitral regurgitation, and remodeling and chronic heart failure. First, let's discuss cardiogenic shock. When can you expect cardiogenic shock? Well, if you have large infarcts. This is such an example, a patient who had a very large LAD and proximal occlusion, and you see that left ventricular function is significantly reduced. We have involvement of the entire septum, the entire apex, and large portions of the lateral wall. What does that mean for the patient? Well, if you have cardiogenic shock, mortality, as you can see here, is significantly elevated. In this study, published in 2009, we see that the mortality, if cardiogenic shock is present, is somewhere in the range of over 60 to 70%. What about myocardial rupture? Well, with respect to the incidence, we really don't know how frequently it occurs. We obviously don't see it very often in the hospital simply because the patients don't make it to the hospital. The mortality is very high, it's 95%. But according to autopsy studies, 5 to 25% of deaths from myocardial infarction are caused by myocardial rupture. This is one of the few cases we were able to document. It was a patient who was diagnosed with this disorder already in another hospital, but who was brought in for surgery to our hospital. So what you see here is you see a very small ventricle with almost normal, or actually normal contractile function. We really don't see a wall motion abnormality here. So many patients only have small infarcts. What else do you see? You see a hematoma right here, pericardial hematoma, which fortunately sealed the defect. Therefore, the patient was able to survive. So the typical features are tamponade, hematopericardium, and often only small infarcts. Obviously, these patients need urgent surgery. A special form of rupture is the so-called pseudoaneurysm. A pseudoaneurysm can be defined as a sealed perforation or also contained rupture. So what happens? Well, you have the myocardial infarction here, and then you have rupture, usually a very narrow channel, and then hematoma and bleeding develops, which is contained both by the pericardium and by the hematoma itself. So the typical characteristics are a short and narrow neck with a diameter of less than 50% of the fundus diameter. The outer wall is formed by the pericardium and the thrombus or hematoma. And what you often also see is you see some form of pericardial effusion, which does not have to be large. Sometimes there are very, very small pericardial effusions in the vicinity of the pseudoaneurysm. It's often quite difficult to detect such pseudoaneurysms. This is an example of a small pseudoaneurysm located in the posterior lateral wall. Color Doppler is actually also not very helpful. What you can do is you can use left ventricular contrast agents, which sometimes help you to delineate this aneurysm a bit better. So this is a pseudoaneurysm in the posterior lateral wall, but you can also find them anterior or inferior. What is more important is that they pose a very high risk of secondary rupture. So these patients need relatively urgent surgery. We already saw an example of an ischemic ventricular septal defect at the beginning of the presentation. But what are the facts? The incidence has been reported to lie between 0.5 and 1%. Mortality is high, 50% are lethal. It usually occurs within 4 to 5 days after the acute myocardial infarction. And risk factors include hypertension, first myocardial infarction, and an anterior location of the myocardial infarction. The typical echo features are hyperdynamic left ventricle. Why? Because we have left ventricular volume overload. We see a disrupted or spliced interventricular septum. We can actually see that with a 2D echocardiogram. However, not always. Sometimes defects are very small and you do not see the morphology of the defect. But you can usually see it with the help of color Doppler. We see the jet, the left to right shunt flow. Continuous wave Doppler can help us to quantify the severity of the lesion. Here's an example. We have an anterior infarct. We see a wall motion abnormality here in the apex. It's very difficult to see, but we see that the septum is very thin here in this region. We have a spliced septum here in this area. You see? Portions of the myocardium are disrupted here. And it's quite apparent with color Doppler that there is a shunt flow between the left ventricle and the right ventricle. If we use continuous wave Doppler, we can see how high the velocity is. In this case, it's 4 meters. And thereby we can actually calculate the pressure difference between the right and the left ventricle. How can we quantify an ischemic VSD, and how can we assess the hemodynamic consequence and sequels? Well, one thing you can always do is you can always look at the morphology. However, this is not very reliable simply because the morphology can be very complex. You can have a spliced septum, you can even have a third chamber formed within the septum. So this is very unreliable. It's probably better to look at the left ventricular volume overload to see if the left ventricle is dilated or not. In addition, you can use the VSD signal, and you can quantify the pressure gradient using the Bernoulli equation. So in this case, you have almost 4 meters, which would mean that you have a pressure difference between the right and the left ventricle of approximately 64 millimeters mercury. However, be aware that you have to have a parallel alignment with the jet, which is often not possible. You can also perform a shunt calculation, the so-called QP-QS calculation. To find out how to do this, you will have to go to the chapter on congenital heart disease, where this will be discussed in more detail. In general, it's probably not that important to really quantify the size of ischemic ventricular septal defects because these patients need to be operated anyway, because the risk is that you have an expansion of the ventricular septal defect and further rupture. And here's a transthoracic echocardiogram of an 82-year-old patient who actually only had a non-transmural infarct and recurrent chest pain. And what we see here is we see the papillary muscle, which is nicely ruptured. You can actually see the rupture site here. This is where the papillary muscle used to be, and it swings down right into the left atrium. Obviously, we have very severe mitral regurgitation. The patient only died 3 hours after this echocardiogram. And here you see a 3-chamber view. Again, beautiful to see the rupture of the papillary muscle and the papillary muscle which swings freely into the left atrium. Here's another demo for you where we try to evaluate if this patient has an aneurysm or not. If we take a look at this patient with an anterior myocardial infarction, we see that by strict criteria, this is not really an aneurysm, but more a dilated apex. You can see how wide the apex is, especially if we use atypical views. So no question that this patient has an increased risk for thrombus formation, and that the patient has an elevated left ventricular volume despite a size of the left ventricle and diastole which is not that large. So it's only 54 millimeters. But if we look at the volume and consider how wide the apex is, the volume is certainly significantly elevated. And here's a demo where I show you how to evaluate a patient with respect to a thrombus and an apical aneurysm. Let's take a look at this patient with an anterior myocardial infarction and try to assess the patient with respect to an apical thrombus. So if we use the normal 4-chamber view, we don't see anything which would let us assume that the patient has a thrombus. Now, to really see the apex, we need to use the atypical views. And what I'm doing now is I'm moving the transducer more laterally. And here we can now see the true apical structures. So if you expect a thrombus, you would probably see the thrombus in here. Now what we have here is we have a few echoes which can be seen here, which could be suspicious of a thrombus. However, if you move the transducer around a bit, you can see that these are just reverberations and that these structures certainly don't meet the classic criteria of a thrombus. So I hope you were able to see that it's not so difficult to really make the diagnosis of acute complication. As I already mentioned at the beginning of the chapter, it's more important that we get the patients to the echo in the first place. The sooner, the better.